everybody, it's Dr. Earle. We're here at Pure Plastic Surgery today, and it's Hump Day with Dr. Earle. So very glad to be back here with you guys. I know I was out last week for vacation, which was great. You know, it was good spending time with the family, getting some time off and everything else, but I'm super excited to be back here with you guys again so that we can spend some time, you know, talking about different plastic surgery related issues and answering all the questions that you may have, and hopefully keeping everyone informed with reliable information regarding plastic surgery. Okay, we got a few kind of cool things that we're going to talk about here today, and also some important announcements that we're going to make towards the end of the talk. So please stay tuned all the way to the very end. Okay. But the first thing I want to talk about, so a couple things have come up over the last few days, couple of weeks. A couple of subjects that have come up that people wanted to discuss. So one of them had to do with the difference between edema and seroma, and how all these things relate to liposuction and BBLs. So as you all know, and you've seen me do this when we tape some of the liposuction cases. One of the very first things that we have to do before we start the liposuction is we actually infiltrate the tissues with the fluid that we call tumescent fluid. Okay, and inside that fluid is normal saline, kind of the same as you would put inside an IV. But also mixed with it, I mix epinephrine. So epinephrine is a drug which vasoconstricts the vessels, and the reason for doing that is to decrease the amount of blood loss during the procedure. So all major liposuction cases nowadays use tumescent, and different surgeons have different things that they'd like to add to it. I keep mine very simple. All I use is the epinephrine to decrease the blood loss. I don't use lidocaine or anything else because I don't want to have any of the potential side effects from some of those other things. Okay, but because we have to instill all that fluid, we then do the liposuction, but then some of that fluid kind of remains. Okay, and when you have fluid kind of within the tissues, then that's what is called edema. Okay, so fluid within the tissues is edema. So think of it like a sponge, right? If you take a sponge and you put it in water and you take the sponge out, there's fluid within the sponge, and so it takes time and also some effort for that fluid to kind of come out. So it can come out usually by your body kind of reabsorbing that fluid. It goes kind of into your bloodstream, and then of course you urinate it out. And that's what's called edema, and that's the type of swelling that takes it takes a while for it to completely go away. Like for the big liposuction cases, we say in the order of at least 3 months and sometimes longer. Okay, now a seroma is different in the sense that a seroma is not fluid within the tissues, but fluid between the tissues. Okay, so a seroma is fluid accumulation between the abdominal wall or the muscles and the skin over top of that. Okay, so a seroma, if it's small, typically your body can take care of it, reabsorb it, and again you urinate that fluid out. However, if it's a large seroma, then sometimes what we have to do is what's called a needle aspiration. Okay, so it's not a very difficult procedure. You just kind of palpate the area where you have the seroma, or you can use an ultrasound to locate the area of the seroma, and then you place the needle through the skin into the seroma and you remove that fluid that way. Okay, so that's the difference there. So edema, okay, is basically kind of like inflammation, fluid accumulation within the tissues. There's no way to needle aspirate that out, right? You can't put a needle, say into the sponge until you can really suck that fluid out. You have to massage it out, and you have to give it time, okay? And then you have seromas, okay, which is fluid between the tissues, and that is the type of fluid that if it's if it requires it, if it's large enough and your body doesn't reabsorb it and it doesn't go away, then you can use a needle to aspirate that fluid. Okay, so I hope that makes things a little bit more clear regarding the difference between edema and seroma. Now the second subject I wanted to talk about real quick before we get to all your questions that some of the ladies asked me to talk about is what's called fat necrosis. Okay, So fat necrosis is another potential complication from fat transfer procedures, and it's really for fat transfer procedures to any area, whether it's the buttock, the breast, or anything else. In fact, most of the research that we have regarding fat necrosis is to the breast. I haven't been doing that much longer. They have been doing fat grafting to the buttock. And so a lot of the studies out there are regarding fat necrosis to the breast. But what is fat necrosis? I know the word sounds very, very scary, that word necrosis, which basically means tissue death. But fat necrosis is essentially that some of the cells that we transfer with the fat transfer did not revascularize soon enough, and also they didn't get absorbed. They didn't get absorbed as well, and so those little cells kind of died and come together, and they form like a little hard ball. I mean, the size depends on the degree of the fat necrosis, but they form like a little clump. Okay, and then sometimes that can be felt as like a little hard ball. There's nothing particularly dangerous about fat necrosis. It's not a cancer, it's not a tumor or anything like that. It's not something that's gonna cause any particular health issues or anything of that nature. So it's not any sort of emergency or urgency, okay? And if it's small, sometimes, most of the times we just leave it alone. We don't do anything regarding the fat necrosis. Now, if it's a bit larger and it's really, really bothering the patient, if you kind of catch it early enough, kind of massaging the area fairly aggressively twice a day can sometimes help your body kind of at least soften it up or break it up and make it smaller, or sometimes it'll go away. Now, unfortunately, there are cases when you have a persistent area of fat necrosis, and if that patient is particularly bothered by it, then potentially we can do some sort of intervention to improve it. So one potential intervention that can be done is to try to just break it up, say with the cannula, some of the similar cannulas that we use for liposuction and for fat transfer. Try to break up an area of large fat necrosis into multiple, like little, much smaller areas, which then are not as bothersome or are more easily, kind of absorbed by the body. That's one option. Or the other option is to basically remove the entire, scar ball. You can think of it as a scar ball of fat, kind of removing that entire area. But then that sometimes may leave a deficit, which then has to be kind of filled again, and hopefully, on the second go round, you don't develop fat necrosis again into that area. Okay, so that's essentially what fat necrosis is. Who gets it? Why? It's very, very variable. It depends on many things. But what I can tell you is that smokers or people that are around smokers, are at higher risk for fat necrosis, and that's because the nicotine causes vasoconstriction. Vasoconstriction means less blood flow. Less blood flow means less oxygenation and less chances of that fat to survive. So that's one of the reasons why I don't do, I won't do a BBL, I won't do a fat transfer in anyone who has a positive nicotine test. So if your nicotine test is positive, unfortunately the morning of surgery, then we would have to postpone that surgery until that nicotine test is negative. So that's one of the reasons why you may have an increased risk of fat necrosis. People that have certain issues with blood flow, such as people with like sickle cell anemia, will probably have an increased risk of fat necrosis, which is one of the reasons why I also don't do a BBL on anyone that has sickle cell anemia. Not sickle cell trait, but sickle cell anemia. I don't do surgery on those patients as well. Okay, and then other things, putting pressure on the area for too long, too early, can also increase the risk. That's why I always try to ask all my patients to try to not put any pressure in the area for the first 6 weeks in order to allow that fat that we transfer to revascularize and not run up into the issues of fat necrosis. Okay, so I've been talking for a little while now. I'm sure there's several questions out there, and you guys have been waiting for me for over a week now. So let's get to it.
I heard that you can lose nipple sensation during a breast aug. Is there an incision that's better or worse for maintaining nipple sensation?
Right, so it is possible to have some degree of changes in nipple sensation with a breast augmentation when you're doing the infraareolar incision, okay? So Okay, so if we're doing this incision here, which is that infraareolar incision in the bottom half of the areola, then yeah, it is possible to have some changes in nipple sensation. This is less, the risk for this is less if you're doing the incision down here, okay, that inframammary incision. So these are the two options that I give my patients, and I tell them, you know, they have to weigh those options. So the disadvantage to the infraareolar incision, like we talked about, is potential changes in nipple sensation. But the advantage is that the scar is very, very easy to hide and it tends to heal very, very nicely. And sometimes because we put it right at that border, it can become like almost imperceptible. Okay. Now this scar down here, the advantage is that there's less risk of any issues with the nipple, but it is definitely, you know, a bit more of a visible scar just because of the location of that, you know, where it's located. So, you know, it depends on what's most important to you. It also depends on what kind of like clothing you wear. Like here in South Florida, as you know, we have many women like to wear very kind of small, kind of triangle type bikini tops, and for that, you know, this incision will definitely be hidden, while this one, you know, potentially could be, you know, a bit more visible. And so there, a lot of women here in South Florida opt for the infraareolar incision.
For patients who don't smoke marijuana or do not smoke cigarettes, what if you're around it? Can that affect your results?
Right, so marijuana on its own is actually okay, even if you smoke it yourself. So marijuana, you know, THC, CBD, and things related to that actually don't increase any risk, you know, regarding the surgery or anesthesia, and that's actually okay. But what is not okay is any sort of nicotine product. So actually, not just smoking cigarettes, but anything, you know, vapes as well, chewing tobacco, anything that has nicotine in it, and if that nicotine gets into your bloodstream, it can affect your results. And so that means secondhand smoke can also affect your results, okay? So if you live in a household where people are smoking around you in enclosed spaces, that could definitely affect your results because it can cause that vasoconstriction, it can cause less blood flow, meaning increased risk of things as, you know, tissue dying, infection, wound breakdown, and things of that nature. Mm-hmm.
How do you process the fat for fat transfer, and why do you prefer that method versus others?
Yeah, so the way that I like to process it is the first thing is we let it separate basically through gravity and time. Okay, so when we remove the fat, you get fat mixed up with fluid and blood, and so you just let it sit, and the fat eventually. Well, we can ask the group here. Does the fat go to the top or to the bottom? Who knows? Any
top.
answers?
We got a top.
All right,
Some
that's
smart
right.
people.
So fat is actually less dense than water. So the fat goes to the top, and then the bloody fluid stays at the bottom. And so then we separate that bloody fluid from the fat, and that bloody fluid is that actually goes into this machine here. Can we see that there? Oh yeah, there we go. We're pointing the cameras over here. So I brought my friend here, the Cell Saver. He is with us here today. We used it today in all our cases, which is awesome. And all the patients woke up really, really well, no lightheadedness or anything of that nature. So that bloody fluid is what we pass through the Cell Saver, where we can separate the blood cells from the remainder of the fluid, and then we can give those blood cells back as an auto transfusion. Okay, and then the fat we then place into a bowl where we add antibiotics. Okay, typically I use clindamycin. We mix that with the fat before we then do the fat transfer, and that's my preferred method. I like that because we can then, you know, take advantage of that bloody fluid to use for the Cell Saver to give you back some of your own blood as an auto transfusion. And then of course I always want to try to do everything I can to minimize the risk of infection, which is why I then, you know, treat the fat with antibiotics to try to minimize that risk as best as possible.
Can Lipo 360 help with hip dips, or do you need to have a BBL to help fill in the hips? I was assuming a small waistline will help hide hip dips.
Well, you know, really the only way to kind of to fill an area, you know, to increase volume to an area is by adding something to that. And so you would definitely would benefit from having a fat transfer to the area. But yeah, sometimes, so the combination of reducing reducing the area on top of the hip dip, bringing in that waist, and then adding some fat to where you have the actual lack of volume, that combination will then can greatly alter the shape and create a more of an hourglass figure. But typically, yeah, you have to do both. You have to do the liposuction and the fat transfer to really try to correct that problem.
If there's a way, how do I prevent keloid scars after surgery?
So keloid scars are tough, and really what predisposes one to a keloid scar, really most of it is genetics, unfortunately. And so, can you prevent it? Well, you to a certain degree you can do a few things to try to minimize the risk of the keloid scar, but the risk will never be zero. So the first thing you want to do is you want to massage that scar. You want to be pretty diligent about doing scar massage twice a day with a silicone-based cream such as Silogen. And then you monitor the scar for at least the first couple months, and in about 2 months you feel that the scar is getting just a little bit too raised. The other thing you can do at that point in time is inject the scar with the Kenalog, okay, which is a steroid, injectable steroid, and that sometimes help prevent the keloid from occurring. Okay, and now if you've already developed a keloid, then the way to treat that many times is to have to actually remove, so basically cut out the keloid, excise it, close the wound again, and then make sure you're very diligent with the steroids and the massage. Okay, and even with all that, there's some patients that are just very, very persistent, unfortunately.
Can birth control affect your results, and is it okay with a BBL?
So oral birth control or estrogen-based birth control does increase your risk of clots. Okay, so those are the DVTs in the legs, the deep vein thrombosis in the legs, and the pulmonary embolus or the clots in the lungs. Okay, so that's why you do not want to be on oral contraceptives for at least 30 days prior to your BBL. So we tell all our patients that are on oral birth control or birth control with estrogen to stop that at least 30 days before surgery to decrease that risk of blood clots. Okay. Now the progesterone-based contraceptives, which can be like IUDs, they can be the implantable ones. Those don't run that risk, and those are actually okay to continue up until and throughout surgery.
Do you do scar revisions? And also, if you have a tummy tuck and are left with dog ears, how do you repair that?
So I can certainly do some scar revisions. Basically what that entails is cutting out the prior scar, which may be either keloid, hypertrophic scar, or a widened scar. So we basically remove that scar and create a new one, and then make sure that we are very diligent about how we treat that scar moving forward. Dog ears are corrected by essentially excising that excess skin, and usually you have to extend the scar in order to try to get rid of the dog ears. So the most common place to have dog ears is kind of in the lateral abdomen after a tummy tuck. And so what you do is remove that excess skin, but say if the incision comes to about here, then sometimes you have to extend the incision kind of around and down up towards the back to get rid of that dog ear. That sometimes has to be done.
We have a lot of questions about combination procedures. Can you just tell us what procedures can you combine with a BBL and what will you not combine with a BBL?
Right, so I think we discussed this actually a little bit just before I left vacation, but the way that you want to think about the easiest way to think about this is that you want to put procedures in two categories. Okay, one is the liposuction and liposuction plus fat transfer category, and the other one is what I would call kind of surgical procedures that require an incision. Okay, and you can combine things in each category, but you can't combine categories. Okay, so for example, can you do liposuction to the trunk and the chin and the arms and combine those? Yes. And can you combine those with a fat transfer? Yes. So you can do a BBL with liposuction to the trunk, the chin, the arms, and the fat transfer to the buttock, and that's okay. And now on the surgical side, can you combine a breast surgical procedure such as a breast lift and a tummy tuck? Yes, you can combine those two there. All right, but can you combine one from this category and one from that category? No. Okay, so you can't do a breast lift and a BBL or a tummy tuck and a BBL. Okay, and I'm saying that for me for sure. I would say for most surgeons in Florida, because in Florida, once you make an incision, you're limited to only 1,000 cc's of fat aspiration with liposuction, which is not a lot. That's generally not a lot to create a big change in terms of kind of the trunk liposuction. It's generally not a lot in terms of to create a big change in terms of the fat transfer, and so it doesn't really make any sense. Okay. I know there are other countries. Actually, you can't do it in the Dominican Republic anymore. They just changed those rules very recently because they were having too many problems with complications and deaths. And these are the reasons why these rules exist. Okay, so yeah, can you go to Colombia? I think in Colombia they still do that. You can still get like a mommy makeover and a BBL all at the same time. But I do not recommend that. I don't think it's safe. I think it's too many procedures all at once. I think the risk of complications are much higher. Risk of death is much higher, and I just don't think it's worth it. I think you want to be on the safer side. You want to make sure you survive all these procedures so that you can enjoy them. And so, in my opinion, a BBL should be basically its own procedure. And then, if you're going to do something after that, surgically related to the breast or the tummy tuck or anything else, that could be done, 3 to 4 months later.
During a tummy tuck, specifically the plication part, can you explain or discuss the healing process and what happens to the muscle?
So we can start kind of with what happened to the muscle before then, right? So if you had pregnancy or you were obese and then you had massive weight loss, the rectus muscles, which kind of come down in the abdomen, and here's say the belly button, they started off pretty close together, and then after pregnancy or weight gain and then weight loss, what happens is that these muscles then got separated, okay, and in the middle here you have what's called a diastasis, okay, which is a separation of those muscles. And so when you do the muscle repair, which is actually kind of a misnomer, the technical term is actually a muscle plication, but when you do that, you're bringing the muscles back together again and closing down this area of the diastasis, okay? And so the muscles that had been separated over time and due to the pregnancy or the weight gain are now brought back together again to the midline, okay? And that's what the muscle repair is. You want to use a big, hefty suture. It can be either a long-term absorbable suture or a permanent suture. I use a long-term absorbable suture called a PDS, but basically it has to be strong because it has to sustain all that while you go through the first 6 weeks of healing. So that's why we tell the patients that you have to be very careful during that initial healing period, because if they have if they lift something that's too heavy during that time, or they do something too strenuous, or even things like if they become too constipated and have to really strain, all these things can unfortunately cause either the stitch to break or to go through the tissue, the fascia, and then cause things to kind of separate out again. So you really want to be very careful with your plication during the first 6 weeks of recovery after a tummy tuck.
How long do you like for your out-of-town clients to stay in Miami after a BBL?
So actually, not just BBL, but for all procedures, all out-of-town clients, especially those that will be taking an airplane, have to be in town for a minimum of 5 days post-op, okay? Not 5 days total, 5 days post-op, okay? So if you're, for example, you're having your surgery on a Monday, you shouldn't leave till Saturday, okay? Saturday is going to be the 5th post-op day. That day you can leave, preferably later, kind of in the afternoon, so that you have time in the morning to kind of stop by and be seen and make sure that everything's okay before you then fly back home, okay? And these are the recommendations that are given to us by the ASPS, or the American Society of Plastic Surgeons, of which I am a member, because that is when it is felt that it is safe again to be able to fly, and the risk of a clot, of a DVT or a PE is low enough for that to occur. If you fly too soon, say post-op day 2, the risk of clots is very high, and then of course those clots can be very dangerous. A pulmonary embolism can cause you to potentially go into the hospital or even worse, it can potentially cause death. So it's extremely important that you stay at least 5 days post-op, and that you do a lot of walking after surgery, that you wear your compression stockings after surgery. And if you're having a long flight, because we are starting to have people come in from Hawaii, from the UK, even Australia. If you're going to have a long flight home, then I very highly recommend the use of what's called the SCDs, or sequential compression devices, for the flight back home. And actually, we have those available here at Pure for purchase if you want to use those. They're called the Circulate SCDs, or sequential compression devices, to help with the blood flow to the legs during a long flight, to make sure that, or to greatly minimize the risk of any potential deep vein thrombosis or blood clot to the legs.
In regards to the muscle plication, what happens if that opens up again later in life, or can that happen?
Oh, sure. So that's why I tell all my patients that I generally don't recommend having a tummy tuck if you think you're going to be having more children. It really doesn't make any sense, to remove the excess skin, get those muscles nice and tight, and then you become pregnant again, and then everything just kind of stretches out again, and the diastasis can develop again, the skin will stretch out again, and then of course you'll probably be looking at a secondary tummy tuck after that pregnancy. So that is definitely one of the procedures where I recommend that you kind of are fairly certain that you're not going to, the family's not going to continue to grow, that you're done having kids before doing the tummy tuck procedure. Then of course the other reason would be massive weight gain, post procedure, which of course is never recommended. You don't want to do that. But if you have a tummy tuck and then you gain a significant amount of weight, that's going to cause things to separate out as well.
Can lipo on the arms cause flaccidity?
It can. So that's why, and I've kind of mentioned it before, but that's why I always say that I'm not too aggressive with a lipo to the arms, because if you're too aggressive and you don't give that skin a chance to retract, it can cause the skin to remain loose. And then of course the only solution to that then becomes a brachioplasty, which is a long scar across the arm, which is not great. So I think in general you want to be a little bit more conservative with a liposuction to the arms. For those reasons, you don't want to create loose or flaccid skin, and you also don't want to create contour abnormalities or kind of divots or things of that nature. So you want to make sure that you're a little bit more conservative. You want to make sure that that everything remains nice and smooth, and that you're able to give that skin a chance to retract back and not hang loose after liposuction to the arms.
Do you have a maximum age that you perform surgery on?
I do, especially for some of the kind of the bigger procedures, say the Monty makeovers and the BBLs. The max age for those procedures is 55 years of age, okay? And that's because those recoveries are tough, and once you start getting into kind of over 55, kind of the risk-benefit ratio is no longer there. Now that doesn't apply, for a lot of the facial procedures though. So, blepharoplasty, which is eyelid surgery, upper and lower eyelid surgery, facelift, neck lift, those are procedures that are okay and safe to do in a little bit of the older population, over 55. We can certainly do those procedures, and actually those are the patients that are searching those procedures are typically in that age range over 55 as well.
Will being around someone that vapes nicotine affect me before and after? Will I test positive for nicotine?
It's possible. It's possible if they're very, very close to you and you're in an enclosed space. It's a possibility. It's not as high with a vape as, say, just a regular cigarette. I want to try to just kind of not be near the person, while they're doing that. And of course, really ultimately, we check everybody. We check everyone's urine for nicotine the morning of surgery, and if that test is positive for whatever reason, whether it's because you smoke yourself, whether you vape yourself, whether you chew tobacco, whether you were near someone that was smoking, or in the club with smoke all around you, it doesn't matter. It just means that there's nicotine in your system, and then if there's nicotine in your system, then the surgery should be postponed until that nicotine has been cleared out of your system.
Do you accept patients from Europe? What are your recommendations for the return flight?
Yeah, so we certainly do, and actually it's been really, really great. We've been getting quite a few patients and a lot of interest from patients coming in from, especially the UK, from England, a lot of patients inquiring from London, but we had recently a patient inquire from Ireland as well, which I was just there on vacation, which is great. So yeah, we certainly accept patients coming in from Europe. And you know, those are longer flights. Those are transatlantic flights, typically at least 8 hours, if not a little bit longer, to get back home. And so it is. Those are the patients where I highly recommend using the SCD machines on the flight, which is those sequential compression devices, which basically squeeze the legs, maintain the circulation of the legs, prevent any blood clots to the legs that can go to the lungs and cause big problems. All right, guys, so it's been great. I think we've answered quite a few questions today. I hope I was able to clear up the differences between edemas and seromas, and also some of the inquiries that you had regarding fat necrosis. But I do want to make a couple of announcements that I had mentioned on the prior live, but I just wanted to mention that again. So number one, the ultrasound, as you guys know, it's basically ready to go. So the date that we're going to be starting using the ultrasound is actually on Monday, next Monday, August 19th, excuse me. So August 19th, we're going live with the ultrasound, okay, with the booty scanner, as I like to call it. Okay, so the booty scanner is starting in less than a week. And that's really awesome. It's just going to make things, you know, even that much more safe for you guys, where we're turning essentially a blind procedure into a procedure where we can see where that cannula is going. Okay, now and then this other announcement, we don't have all the details just yet, okay, but we are very soon, actually maybe the next day or so, we're going to launch a before and after contest. Okay, so we're a little bit over mid-year. I've done you know, basically hundreds of cases so far. I know there's a lot of patients out there that are ecstatic. They're super happy with their results, and we want to see you, and other patients want to see you, and future patients want to see you. So basically what the contest will entail is that you are going to send us your best looking before and after shot. Okay, your best looking before and after photo, and then we're going to go through all of them, and we're going to choose, you know, what we think is the nicest one, the best one. We may choose maybe more than one, but we'll see. And then that person, that winner, will get $500 in cash, just a cash prize, no strings attached, no having to come down up here and get another procedure or anything like that. So we're really excited about this. I hope you guys really partake. We want to see everyone, you know, who's had surgery this year and is happy with the results. Go ahead and send those to us, and we're going to give you more details as to where to send them, but it's probably going to be through direct messages on Instagram. Okay, and anyone who's had surgery with me this year or any time in the past is a participant for this giveaway. All right, guys. So I'm really excited to see some of these before and afters. So you know, wear your, you know, whatever you want to wear, make it look nice, and you can be creative as well. So I'm really excited to see what you guys come up with. Okay, everybody. Okay, so that's it for today. But we'll be here next week on Hump Day with Dr. Earle. Take care, everyone. Ciao.